Good evening, all. Welcome to Smart Root Academy. So, today we are going to discuss about heart failure. So, this is a very important topic, and this class is not just about heart failure. We will be discussing some associated condition, and we will also discuss digital therapy in detail. Okay, so let's start the class. And before discussing about heart failure, and before discussing about this heart failure, we will also discuss about some basic terminologies that is very relevant, that is very helpful for you for studying this cardiovascular conditions. Okay, so let's start the class. So these are the basic terminologies. So this is first one is afterload. The resistance left ventricle must overcome to circulate blood. Okay, so afterload means for the left ventricle to pump out or eject out blood, they should overcome some peripheral vascular resistance. So this is known as afterload. Okay, then preload. Preload is the volume in the ventricles just before ventricular contraction. Okay, just before the ventricular contraction, what is the volume of blood present in the ventricles? That is preload. Okay, so this preload will help us to know about the stretchability or the stretching capacity of the stretchability of the heart. We can assess with the help of this preload. And regarding this afterload will be increased in hypertensive conditions. Okay, then stroke volume. What is stroke volume? The volume ejected by each ventricle in one contraction or one heartbeat. In one contraction or heartbeat, what is the blood volume ejected by each ventricle? Okay, so that is stroke volume. Then cardiac output. Cardiac output is the amount of blood heart pumps in each minute. In each minute, what is the amount of blood heart pumps? This is normal. Normal in rest, it is 5 liter per minute. Almost same for everyone, but in rest time, it is 5 liter per minute. And it can differ according to the metabolic needs of our body. This cardiac output will differ. Okay. Then cardiac index. So cardiac index is the ratio of cardiac output to total body surface area. According to our total body surface area, what is the ratio of cardiac output? Whether that is enough or no. So for assessing that, we will be checking cardiac index. Okay, for all of these three, the stroke volume, cardiac output, then cardiac index, these three are having different formulas. So we will be discussing that in the next slide. And one more thing is there, that is the ejection fraction. It's the fraction of the end diastolic volume of blood which is getting ejected by the ventricles each beat. So with each beat, there will be some fraction of the end diastolic volume of blood which is getting ejected with each beat. So this is known as ejection fraction. So this is a very important test or a thing that should be assessed in heart failure. LVEF, left ventricular ejection fraction. So then this is normal. It is 55 to 70%. 55 to 70%. We can say it is a normal for ejection fraction or left ventricular ejection fraction. So this one we will check in heart failure. Okay. So next we are going to see normal hemodynamic parameters. Okay. So how to calculate these things? Cardiac output. The equation is heart rate into stroke volume. Okay. The normal range, we cannot say normal range. In rest, it will be 5 liter per minute. Okay. 5 liter per minute. And it can be increased up to 7-fold according to the body demands or the metabolic demands. Okay. In heart rate, the average is how much? 72. And stroke volume, we can say it like 70. Okay. Then what is the cardiac output? It is 5040. We can round it off to 5 liter. Okay. So this is the cardiac output. In this way, the cardiac output will be calculated. Heart rate into stroke volume is cardiac output. Okay. Normally is 5 liter per minute. Then cardiac index. Cardiac index is cardiac output divided by body surface area. Body surface area we will express in meter square. Okay. So body surface area, how we will calculate? That is root of height in centimeter into weight in kg divided by 3600. This is the formula for calculating body surface area in meter square is equal to root of height in centimeter into weight in kg divided by 3600. This is for calculating body surface area. Okay. So this body surface area in males, the normal body surface area is usually it is 1.9 meter square, and in females it will be 1.6. Okay. So this is average only. So in this way, the cardiac output, what is the cardiac output given? If they are asking to calculate the cardiac index, then the cardiac output and BCA will be given. So cardiac output divided by BCA you can do. Otherwise, they can ask the formula also. So you should better by heart these formulas. So the normal range is 2.5 to 4 liter per minute per meter square. Okay. So 3.2. We can say it 3.2 as an average for cardiac index. Next one is stroke volume. Okay, stroke volume is cardiac output divided by heart rate into 1000. Okay, cardiac output divided by heart rate into 1000. Cardiac output we estimated like 5 liter divided by 72 into 1000. How much it will be? Around 69. Okay, now we can round it off to 70. Okay, 70 is the average stroke volume. So these are the formulas. Cardiac output is heart rate into stroke volume. Cardiac index is cardiac output divided by body surface area, total body surface area. Then stroke volume, cardiac output divided by heart rate into 1000. Okay. So next we are moving on to the definition of heart failure. So these basic terminologies you should know, then only you can go further. So heart failure is defined as a complex clinical syndrome that results from any structural or functional impairment of ventricular filling. Ventricular filling is diastole and or ejection of blood, that is systole. So any structural or functional changes will be happening to the heart. Specifically, mainly it will happen first in the ventricles, and it will affect the ventricular filling as well as ejection. Both diastole and systole will be affected. Okay, so this is the definition of the heart failure. Further, we are discussing about the etiologies. So the main etiology: CAD, coronary artery disease, hypertension, rheumatic heart disease. So when you get a question like the most common reason or the most common reason for heart failure is CAD, coronary artery disease. Okay, then hypertension and RHD is also factors, but the most common is coronary artery disease. The other reasons are congenital heart diseases like VSD, ventricular septal defect, tetralogy of Fallot. So these congenital heart conditions. Then cor pulmonale. So how this is happening? Cor pulmonale is a result of chronic lung diseases. Okay, chronic lung diseases will cause right ventricular failure. So that is known as cor pulmonale. So this can happen in, can you say an example of chronic lung disease? COPD. Okay, COPD, like not just COPD, but in COPD is a chronic lung disease. So in this condition also we can see core pulmonale. So due to the chronic lung disease, right ventricular failure will happen. That is known as core pulmonale. This can also contribute to heart failure. Then cardiomyopathy. Cardiomyopathy is the structural changes in the heart. So cardiomyopathy is again divided into three. So cardiomyopathy, it is dilated cardiomyopathy is there, hypertrophic cardiomyopathy is there, and restrictive cardiomyopathy is also there. So in dilated, what is there? In dilated, the size of the heart will increase. That is, cardiomegaly will happen in dilated cardiomyopathy. Okay, but the walls will be very weak, but enlargement is happened. That is happening in dilated cardiomyopathy. In hypertrophic, what will be there? Increase in the cells, the hypertrophy of the cells in the ventricles. Mostly it is happening in the ventricles. That is the left ventricle. It will be happening. So hypertrophy of those ventricles will be there in hypertrophic cardiomyopathy. And in restrictive, what will be there? Stiffness will be there. Stiffness of the chambers of the heart will be there. Okay, so these are the major three types of cardiomyopathy: dilated, hypertrophic, and restrictive. Dilated is the most common type. Okay, dilated is the most common type. Then bacterial endocarditis or infective endocarditis, so valvular disorders will be causing, and that can finally leads to heart failure. Then other reasons are other valvular diseases, acute MI, myocardial infarction, pulmonary emboli, ventricular septal defect, and myocarditis, inflammation of the myocardium. So these conditions can cause finally heart failure. Okay, so we will discuss further in pathophysiology. So these are the major conditions. Most common cause is coronary artery disease. So what are the types of heart failure? So, according to the types of the failure, the clinical features also will differ. Okay, so in some questions you can get the symptoms, and you can they can give you options like to assess the condition or which type of heart failure and all. So those things we will be discussing in the session. Left-sided heart failure and right-sided heart failure are the most common one. Left-sided heart failure, what will be there? Results either from the inability of the left ventricle to empty adequately during systole or fill adequately during diastole. Okay, so there will be left side will be having problem, so that the ventricle cannot empty or cannot eject out the blood or cannot fill properly also. This can the filling and ejection problem can also happen in coronary artery disease, cardiomyopathy, and all. Filling also will be difficult, because in restrictive cardiomyopathy, what will be there? There will be stiffness of the chamber. So the major benefit or the major advantage of the cardiac muscles or the property of the cardiac muscles is elasticity. So that will be lost in cardiomyopathy. So those conditions can easily lead to this heart failure. Right-sided heart failure. Right-sided heart failure, right ventricle fails to pump effectively. Okay, so this can happen in conditions like chronic lung disease. Okay, in right-sided heart failure mostly will be occurring either due to this left-sided heart failure or due to any chronic lung diseases. Okay, so if the right ventricle is not pumping out the venous blood adequately, fluid backs up into the venous system, which causes movement of fluid into the tissue and organs. Okay, so in right ventricles, they are not pumping out the blood adequately. So what will happen? The fluid will go back. You know the anatomy of the heart. If right ventricle is not pumping adequately, fluid backs up to right atrium, then to inferior vena cava, to liver. So hepatomegaly, splenomegaly, ascites, everything we can expect from this condition. So right-sided heart failure and left-sided heart failure is one classification. Next is biventricular heart failure. You can understand it is the both of the ventricles, both right and left ventricular heart failure occurred. Then diastolic dysfunction and systolic dysfunction. Diastolic dysfunction due to poor ventricular filling and high filling pressures caused by abnormal ventricular relaxation. Relaxation is not occurring adequately, so diastole or filling in of the blood is not occurring properly. In systolic dysfunction as a result of impaired myocardial contraction characterized by reduced ejection fraction and enlarged ventricle size. So myocardial contraction is not occurring properly. So we have to increase the contraction or the force of the contraction. Okay, so that we can increase the ejection fraction. So this is about systolic dysfunction. This is another classification. Low cardiac output syndrome. There is reduced cardiac output. High blood pressure and hypovolemia results in impaired peripheral circulation and vasoconstrictions leading to low output failure. Okay, so high blood pressure will be there and hypovolemia, decreased volume. So this results in impaired peripheral circulation and vasoconstrictions will be happening. So automatically it will lead to low cardiac output. So due to this, heart failure can occur. Even due to high cardiac output also, this can occur. In high cardiac output states, increased metabolic requirements are seen in hyperthyroidism, fever, pregnancy, or may be triggered by hyperkinetic condition, increased movement or increased workload, okay, such as arteriovenous fistulas, anemia, and beriberi. Okay, so these conditions, what will be there? Increased metabolic requirements, as in hyperthyroidism, increased metabolism, fever, and pregnancy. In these conditions, metabolic requirements will be high. That will lead to high cardiac output syndrome, finally leads to heart failure. Acute heart failure, chronic heart failure, you know, spontaneously or a sudden deterioration in cardiac function occurs, then acute. So gradually it is occurring due to any chronic diseases, high BP or COPD, we will call it like chronic heart failure. So these are the major classification. Even forward and backward failure is also there. So this one, NIHA classification. What is NIHA? New York Heart Association. Okay. So this is one of the major classification we will see in patients suspecting heart failure. Okay. So let's see the gradings. So there are different classes. Class 1 is no limitation of physical activity. Ordinary physical activity does not cause fatigue, dyspnea, palpitation, or anginal pain. So in NIHA classification, the class 1 people, they are not having any limitation in physical activity. They can do any physical activity. They are not having any fatigue, dyspnea, palpitation, or anginal pain during activities. That is class 1 people. Then class 2, slight limitation of physical activity, no symptoms at rest. At the time of rest, there will be no symptoms, but during some sort of physical activities, they will be having symptoms. In class 3, marked limitation of physical activity, usually comfortable at rest. In this class 3 also, they also will be comfortable at rest, but there will be, if they are doing some little amount of activity also, they will be having dyspnea, fatigue, or like that symptoms. Okay, so in class 2, only slight limitation. They can do most of the activities. Some strenuous activity they have to avoid in class 2. In class 3, marked limitation of the physical activity. Most of the activities they cannot do, but they are comfortable at rest. Class 4 is the final class in this, inability to carry on any physical activity without discomfort. So they are the most sick patients. So these class mostly come under this heart failure patients. Symptoms of cardiac insufficiency or angina may be present even at rest. At the rest time also, they will be having symptoms. Any physical activity is undertaken means they will be having the symptoms. So this Class 4 people, the most sick patient. So this class, so whenever a patient coming with this heart failure, we will use NIHA classification to identify their activity level or their severity of their heart failure. Okay. Next, we are moving on to the pathophysiology of heart failure. So as we already discussed, CAD or coronary artery disease, one of the major factor that will lead to clogged arteries or blocked arteries. Or hypertension, as I already said, there will be increased afterload in hypertension. Both will lead to decrease in stroke volume. Stroke volume will be decreased. That means what will be there? Decrease in cardiac output. Okay. So due to the abnormalities in the heart, due to decreased stroke volume, increased afterload. Afterload means the resistance is increased, so that stroke volume is decreased. And finally, the cardiac output is decreased. So due to this decreased cardiac output, three main things can happen. So due to that, the heart failure will occur. So let's see the first thing, that is increase in heart rate. So the body, if our body is having some problem or it is facing any problem, it will try to compensate it. So this is one of the body's compensatory mechanism to increase the cardiac output. First one is increase in heart rate. So due to increase in heart rate, what will be there? The heart is beating fastly. So it want to eject the blood out more. So what will be there? Decreased filling time. Volume in heart chamber decreases. The volume which is coming to the heart or filling time is decreased because the heart is beating fast to eject the blood out. So what is happening? Filling time will be decreased. That will lead to congestive heart failure. That will worsen the condition and leads to heart failure. Next, second one is structural changes. What are the structural changes? What is the problems happening to the muscles of the heart? Dilated cardiomyopathy, in that part will be there thin ventricle. Okay, thin ventricle. So in dilated, I already said the muscles will be weak or very thin, but it is enlarged. Size will be enlarged. And due to that, what will be there? Unable to pump. The contraction will be affected and unable to pump out adequate blood. That will lead to heart failure. Next reason is hypertrophic cardiomyopathy or thick ventricle. If the ventricle is very thick, what will happen? It will become stiffer. So it doesn't fit well. So decreased ejection of blood. That will also lead to heart failure. So these two conditions also contribute to heart failure. Then the third factor is the kidney. Kidney, it is you all know about this mechanism. This is RAS mechanism, renin, angiotensin, aldosterone system. So this mechanism will be activated in case of hypotension or hypovolemia. Okay, so to increase BP or to increase the fluid volume. So due to this decreased cardiac output, what will be there? The RAS mechanism get activated. That means the kidney will release renin. Okay, kidney will release renin. Then angiotensinogen to angiotensin 1 and 2. So here it is a shortcut. So we should know from where this angiotensinogen is secreted. Renin is secreted from the kidney. Angiotensinogen is secreted from liver. Okay, so from liver, this angiotensinogen is already secreted. So this renin will act in the angiotensinogen. Okay, so that it will be converted to angiotensin 1. Okay, so to this angiotensin 1, angiotensin converting enzyme or the ACE will act to the angiotensin 1, then it will be converted to angiotensin 2. So this is the mechanism. This ACE, it is secreted from where? Angiotensin converting enzyme will be secreted from lungs. Okay, so this is the mechanism. You should know from where these enzymes or from where these things are secreted also. Okay, so from the kidney, the renin will be released, and the angiotensinogen is released from liver. This renin acting to the angiotensinogen converted to angiotensin 1. Then angiotensin converting enzyme, which is secreted from the lungs, will convert this angiotensin 1 to angiotensin 2. Okay, so this is happening, and finally there will be release of aldosterone. So if the aldosterone is it's released, what will be happening? Sodium and water retention. Okay, and also the angiotensin 2. The angiotensin 2 is also a potent vasoconstrictor. So this will also try to increase the BP. Aldosterone also will be secreted. Angiotensin 2 will stimulate the adrenal medulla to release aldosterone, so that sodium and water retention will occur. So finally, it will lead to volume overload. So that's why this heart failure patients, they are so much edematous. Okay, so in this way, the volume overload also will happen for the heart failure patients. Then we are moving on to the one of the major area, clinical manifestations. So according to the type of the heart failure, the clinical manifestations vary, and you should know in which heart failure which symptoms are coming. So if you know the base, you can remember it clearly. So this is a cartoonic representation. So in this you can see an left side what will be happening. Left side, what is the function of the left ventricle? To eject out the blood. So due to this systemic resistance, what will be there? The left ventricle cannot eject out blood. So what is happening? Backflow of the blood to the left atrium will be happening. From the left atrium, it will go to the pulmonary veins to the lungs, so that the backflow of blood to the lungs will be happening. Finally leads to pulmonary congestion. Okay, pulmonary congestion will be happening, so that the manifestations will be dyspnea, orthopnea, paroxysmal nocturnal dyspnea. This is one of the classic symptoms in heart failure. Okay, you should note this one. Paroxysmal nocturnal dyspnea is one of the classic symptoms in heart failure. So dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and all other breathing difficulties or any pulmonary manifestations, mostly it will be there in right heart failure. So left heart failure. So left-sided heart failure, pulmonary manifestations will be there. And in right-sided heart failure, what will be there? In right-sided heart failure, mostly occurring due to left heart failure. Okay, mostly right-sided heart failure is occurring due to left heart failure, or what reason we already discussed? Chronic lung diseases. So due to this, what will be there? Increased resistance in the pulmonary artery will be there. Okay, so left heart failure is most common cause of the right heart failure. So increased pressure in the pulmonary circulation. So if the right heart is failed, then it will cause increased pressure in the pulmonary circulation. So this increased pressure in the pulmonary circulation can also occur if there is a chronic lung disease also. So by this way, cor pulmonale or failure of the right ventricle will occur. Okay. So in this way, this can also happen. So what is happening in this? So this is the pulmonary artery. Okay. So the right ventricle cannot eject blood to the pulmonary artery because of the resistance, increased resistance in the pulmonary artery. The right ventricle cannot eject out blood. Okay. So what will happen? The blood flows back, the venous blood flows back to the right atrium, and from the right atrium it goes back to the IVC, then to different tissues and organs. So here you can see hepatomegaly and cardiac cirrhosis. Hepatomegaly is the inflammation of the liver due to venous blood accumulation, and cardiac cirrhosis. Cirrhosis, you all know, that is the hepatic cells will be distracted in cirrhosis. If you are saying it like cardiac cirrhosis, the cirrhosis or the destruction of the hepatic cells is happened due to some cardiac reasons like heart failure. So these two are some manifestation. Then renal failure due to fluid accumulation. Azotemia. What is azotemia? That is accumulation of nitrogenous base products in the body is known as azotemia. So this will also occur. Peripheral edema, mainly pedal edema we can identify. Then ascites, accumulation of fluid in the peritoneal cavity can also be happen. So fluid overload is the main manifestation in the right heart failure, and you should also note increased JVP. Jugular venous pressure also will be increased. So in right heart failure and left heart failure, the symptoms varies. So the reason also I discussed. So here you can see some mnemonics. Okay, do chap is the mnemonic for symptoms of left heart failure. So these are about the pulmonary manifestations. So dyspnea, breathing difficulty, orthopnea according to position change, the breathing difficulty. Then cough, hemoptysis is presence of blood in the sputum. Adventitious breath sounds means abnormal breath sounds. Normal vesicular sounds won't be there. Some abnormal breath sounds we will get due to pulmonary congestion. So P is pulmonary congestion, and also you can say it like PND, paroxysmal nocturnal dyspnea. What is this condition? Paroxysmal nocturnal dyspnea. The patient will be having, won't get adequate sleep. They will wake up after 1 or 2 hours of sleep, and because of the breathing difficulty or dyspnea, they will wake up from the sleep after 1 or 2 hours, and it is this dyspnea is relieved by upright position. So sleeping, they are in supine position, no. So at that time they are having breathing difficulty, so they will wake up after 1 or 2 hours. So then the symptoms will be relieved mostly by upright position. So this is paroxysmal nocturnal dyspnea. Okay, so these are the symptoms in LHF. And in RHF, what is there? Oh, head. Okay, so if you are having pain in head, we used to say like that. So this is also a mnemonic. You can remember like this. A means anorexia and nausea. W, weight gain. Weight gain is due to edema. Okay. Then hepatomegaly, increased size of the liver due to venous blood congestion. Edema, obviously it will be there. Ascites and distended neck vein or increased jugular venous pressure. Okay, so this can be there in right heart failure. So these are the clinical manifestations. Then what are the complications of this heart failure? Pleural effusion, we already discussed. Pulmonary congestion will be there. Dysrhythmias can be happening. AF is also common in heart failure, atrial fibrillation. Then left ventricular thrombus. How this left ventricular thrombus is happening? Due to venous stasis or blood stasis. This thrombus, if the blood is slowing down, then there is a chance for thrombus. Then hepatomegaly is a complication. Then renal failure. Then we are moving on to the diagnostic test. Okay, so in this also there are important points. History and physical examination, this is common for everything. And next one, Framingham criteria. Okay, for assessing or for diagnosing the severity or for diagnosing the heart failure, we will use Framingham criteria. So there are major criteria as well as minor criteria. Okay, in major criteria, the classic symptoms or the major symptoms will be there. Okay, this include PND, we already discussed. Neck vein distension, rails, cardiomegaly, acute pulmonary edema, S3 gallop, we can hear through auscultation. Then increased venous pressure, positive hepatojugular reflex. Okay, so these symptoms are in major criteria. Sorry, signs are in major criteria. Then in minor criteria, there will be edema of the extremity. Night cough will be there. Dyspnea on exertion. While doing activity, they will be having dyspnea. Hepatomegaly. Pleural effusion due to pulmonary congestion. And vital capacity reduced to 1/3 from normal. And tachycardia, increased heart rate. Okay, so these are major and minor criteria in Framingham criteria. So these major and minor criteria will be there in Framingham criteria. So how we will assess, how we will interpret? That is either two major criteria. We should assess the patient on admission. So we will assess if you are suspecting heart failure. We will use this Framingham criteria. We know the symptoms. So we will assess the patient. If you are getting two major criteria, we can say that the patient is in heart failure condition, or we have to get one major criteria and two minor criteria. Okay. Either two major criteria should be there for diagnosis of heart failure, or one major criteria and two minor criteria should be present for heart failure. So this is one of the important point. Then in ECG, we will check for diagnosis. In ECG, left ventricular hypertrophy or prior MI, we can see. Echocardiography is one of the major investigation. So in echocardiography, we will get information about EF. What is EF? Ejection fraction. Okay, structure and function of the heart valves we can see with echocardiography. Heart chamber enlargement also we can see with echocardiography. So EF, I already said, what is the normal? 55 to 70%. Okay, 55 to 70% is the ejection fraction. Okay. Then heart failure with reserved EF and preserved EF is there. So if it is with reserved EF, it will be less than 40%, and heart failure with preserved EF more than 40 to 50% will be there. So these are about the diagnosis. Chest X-ray. In chest X-ray, what we can see? Heart rate and shape, heart size and shape. Then pulmonary edema also we can observe with chest X-ray. Biomarkers. So this is also one important thing. You should remember, in heart failure, the thing we should check is BNP, B-type natriuretic peptide, or N-terminal pro-BNP also we will check. BNP or N-terminal pro-BNP. So this, how this will be significant in heart failure. This will be released from the failing heart. So mostly from the ventricles it will be released. Okay, from the ventricles these BNP will be released due to excessive stretching. Due to excessive stretching, this BNP will be released from the failing heart. And even other biomarkers like troponin T, I, CRP, uric acid can also be elevated. But the significant thing, that because troponin T and I, we will mostly check in MI and all. Okay, so the significant thing we will check in, the main thing we will check in heart failure is BNP or N-terminal pro-BNP. Okay. Other routine laboratory testing are CBC, complete blood count, one electrolytes, serum creatinine, hepatic enzymes, urine analysis, dyslipidemia, thyroid abnormalities. Because we already said that due to increased metabolic demands, thyroid abnormalities like even hypothyroidism can also cause this heart failure. Okay, so you should remember these things. Then medical management, this is one of the important part in this heart failure. So in that, there is a mnemonic, that is unload me. What is U? That is upright position. Okay, upright position. This is for relieving dyspnea or for relieving breathing difficulty in the patients. Nitrates or nitroglycerin. Then Lasix, it is a loop diuretic. Usually, how much we will give? 20 to 40 We will give this for initial therapy, 20 to 40 mg we will give. Then oxygen, obviously we have to give if the patient is having dyspnea. Then AC inhibitors we will give. This is for, you know, the RAS mechanism, so we can rationalize why these AC inhibitors are being given. Then digoxin. Digoxin is a very important drug in heart failure, and there are many questions from previous papers also regarding this digoxin therapy, so we will discuss it in detail. Then morphine sulfate for reducing pain, and extremities should be down, so that is unload me. Okay, upright position, nitrates, Lasix loop diuretics, then oxygen supplements, then AC inhibitors, digoxin, morphine sulfate, and extremities down. Okay. So next we are moving on to digoxin therapy. Okay. So the typical daily dose usually ranges from 0.0625 mg to 0.25 mg per day. Okay. So usually we will give this daily dose of 0.0625 mg to 0.25 mg per day. But the usual standard initial dose will be 0.125. Okay, this one you should remember. The initial dose, the standard initial dose will be 0.125 mg for digoxin therapy. Then you should know therapeutic levels of digoxin ranges from 0.5 to 2 mg per ml. In some textbooks you can find 2.2 also. So 0.5 to 2 can keep like that. So therapeutic levels of digoxin ranges from 0.5 to 2 mg per ml. This one you should remember. Okay, because digoxin is a drug with a very narrow safe range. If the digoxin levels are reduced in the blood, it will cause exacerbation of the symptoms. If it is increased in the blood, it will cause toxicity. So this level is very important. Therapeutic level of digoxin is very important. So, and the main thing about digoxin is it is having mainly three effects: positive inotropic effect, negative dromotropic, and negative chronotropic effect. So what are these things? Positive ionotropic effect means it will increase contractility. It will increase the contractility. So if the contractility is increased, what will be happening? The force of contraction will increase. Okay. And negative dromotropic effect. Negative dromotropic means it will decrease the conductivity. The conduction will be decreased. So automatically what will be there? Negative chronotropic effect. That means it will decrease the heart rate. Okay. So these are the main three effects of digoxin. Positive inotropic means increase the contractility. Negative dromotropic means decrease the conductivity. And third effect, negative chronotropic effect, that is, it will decrease the heart rate. And these two findings, ST depression and T wave flattening, you can see in digoxin therapy. Normal digoxin therapy, the therapeutic effect, if the digoxin is given to some patient, normally ST depression and T wave flattening we can observe. So that is about the digoxin therapy. In the action, mechanism of action, the digoxin, it will bind to the ATPase pump, sodium or potassium ATPase pump. So the thing is, the digoxin is binding to the same receptor of potassium. Okay, so digoxin is binding to the same area or same receptor from where the potassium is also binding in ATPase pump. It will increase the calcium and contractility will be increased, or force of contraction will be increased. So that is one side. Then digoxin will also increase the vagal activity, or it will cause or stimulate the vagus nerve. So if vagus nerve is stimulated, AV conduction will be decreased. Atrioventricular conduction. Last class we studied about cardiac conduction system. So you know that if AV conduction is decreased, what will happen? Decreased or shortened PR interval. Shortened PR interval we can observe in the digoxin therapy. Okay, then decreased rate, heart rate also will be decreased. Then digoxin toxicity. Okay, so we already said that toxicity means if it is more than 2 ng per ml. If the digoxin level, serum digoxin level is more than 2 ng per ml, it will lead to digoxin toxicity. So I already said how it is happening, this digoxin toxicity. The digoxin toxicity is caused or precipitated by hypokalemia or decreased potassium level. If decreased potassium level is there in blood, it will aggravate the potassium toxicity. Okay. So how it is happening? Because digoxin and potassium is binding to the same receptor. So in scene A and scene B, you can see in scene A, there is zero toxicity. No toxicity is there in scene A. Why? Because there are adequate amount of potassium and there is some amount of digoxin also. Okay. So this receptors will be filled with some receptors will be, the potassium is binded to some receptors and in some receptor digoxin is binded. So there is no toxicity. In scene B, you can see there is hypokalemia. There is not enough potassium. Okay. So what will happen? So many receptors are free here. The potassium is not present in our body or we are experiencing from hypokalemia. So that the potassium is not binding to the receptors. So what will happen? Digoxin will get more receptors to bind. So that will finally lead to digoxin toxicity. So you should not confuse. In hypokalemia or decreased potassium level, it will cause digoxin toxicity. So this one, premature ventricular complex is the most common arrhythmia we can expect in digoxin toxicity. Antidote will be digoxin specific antibody. So I said that the digoxin toxicity is potentiated by hypokalemia or decreased potassium level. The next point is digoxin toxicity causes hyperkalemia. He said that toxicity is happening due to hypokalemia, but if once this digoxin toxicity occurred or it is there, if the digoxin toxicity already occurred means it will cause hyperkalemia. Hyperkalemia means increased level of potassium in the blood. How it is happening? Because digoxin is binding to the, if in case of hypokalemia, the digoxin toxicity occurred, and once the digoxin is binded to those receptors of potassium, it will inhibit the potassium from coming inside. So what will happen? There will be increased level of potassium in the blood. Okay, so that will cause hyperkalemia. I think you are clear with it. If you have any doubt, you can ask in the last. Then side effects include visual disturbances, GI disturbances, and bradycardia. So visual disturbances. So side effects of digoxin is also very important. In visual disturbances, we can expect blood or yellow vision. So this is a question from NIMHANS. Last NIMHANS exam, they asked this question. The visual disturbances in digoxin therapy, blood or yellow vision we can expect in digoxin therapy, or side effect of the digoxin therapy is blood or yellow vision. GI disturbances, we can expect anorexia. Then nausea and vomiting also we can expect in the side effects of this digoxin therapy. Then bradycardia, obviously it will occur It will decrease the heart rate. So there is one criteria for adults, for children, and for infants. So when we can start the digoxin therapy or when we have to stop. That is, in adults. In adults, if the heart rate is less than 60 beats per minute, we won't start the digoxin therapy or we will stop the digoxin therapy if the adult is having less than 60 beats per minute heart rate. In a child, if the heart rate is less than 70 beats per minute, we will stop the digoxin therapy or we will not initiate digitalis therapy. And in infant, if the heart rate is less than 90 beats per minute, we won't initiate digitalis therapy. So this will differ in adults, child, and infant. Okay. So this is about the side effects of the digitalis. Then T-wave inversion in ECG and arrhythmias can be expected in digoxin toxicity. What we discussed earlier in ST depression and T-wave flattening. See the last point, ST depression and T-wave flattening is there in therapeutic effect. If therapeutic effect is there, T-wave flattening we can occur. Flattening of the T-wave. Usually T-wave will be, there will be some positive deflection will be there. But in therapeutic effect, there will be flattening. Okay, flattening will be there in therapeutic. And in toxicity, T-wave inversion will be there. And some arrhythmias also we can expect. The most common is premature ventricular complexes we can see in digitalis toxicity. And atrial fibrillation also will happen in final stage if the toxicity is increased. Okay, so these are about the digoxin toxicity, how it will be potentiated, and digoxin toxicity, once it happened, then what it will cause, then what are the major side effects, and what are the ECG changes that we can observe in digoxin therapy. Next is about the surgical management. So here you can see, this is one of the surgical management, and this implantable cardiac defibrillator is there. In image also you can observe this. The implantable defibrillator is inserted in under the skin. So this is like the pacemaker. Pacemaker is inserted where? Pacemakers will be inserted in the subcutaneous tissue below clavicle. The location of the permanent pacemakers I am telling, that is in subcutaneous tissue below the clavicle it will be located. So like that only, this implantable cardiac defibrillator also we will be inserted under the skin. So there will be, and this defibrillator we are inserted here, and the image itself you can see the wires are going inside the heart. And you can see the electrodes will be placed in the heart. Right atrium and ventricle, it will be placed. So what is the use of this? In cardiomyopathy, VTAF and all, we will place this implantable cardiac defibrillator. It cannot improve the quality of life. That means the patient's activity should be restricted only. It doesn't have the ability to re-synchronize and all, but it is shockable. That means if the patient is placed with this implantable cardiac defibrillator, at some point of time, the patient is experiencing any severe dysrhythmias, and if there is any life-threatening conditions due to arrhythmias, this defibrillator, which is placed in the skin, automatically will give a shock. Okay, so that arrhythmia can be resolved. So it will protect from fast heart rhythm. Arrhythmias, it will protect. So the patient's life can be saved. So this is implantable cardiac defibrillator. If the heart failure is not managed with medical, we cannot manage it with medical therapy only, we will go for this surgical therapies. Next one is cardiac re-synchronization therapy defibrillators. Previously, we discussed about defibrillators only that cannot resynchronize. So what is the significance of this one? In this cardiomyopathy plus heart failure, we can use electrical conduction problem. In electrical conduction problem is there, so that we can use it. Will improve the quality of life too, because it can resynchronize according to the activity of the person. It can provide it will resolve the electrical cardiac conduction also. So it will improve the quality of life also. Resynchronize the ventricle to improve the heart pumping ability. Okay, so that's why it is improving the quality of life. If the patient is doing some more work, some exertion is happening, then this defibrillator, which is already implanted in the sim, will resynchronize and it will help the ventricle to improve heart pumping ability. Next one is cardiomyoplasty, a surgical procedure in which healthy muscles, that is latissimus dorsi, that is the muscles in the heart, from another part of the body, a surgical procedure in which healthy muscle from the, this is healthy muscle from the other part of the body. So mostly used muscle will be latissimus dorsi. This is from the another part of the body, is wrapped around the heart to provide support for the failing heart. So in heart failure, what will be happening? The muscles of the heart is undergoing structural and functional abnormalities. Okay, so in this case, what we will do in cardiomyoplasty, we will place mostly latissimus dorsi muscles. We will be using latissimus dorsi muscles. This will be taken from another part of the body and we will wrap those muscles around the heart to provide support. If the heart muscles cannot, the heart muscles cannot contract and relax easily, or they are failing. So in order to produce or provide support to these heart muscles, we will be wrapping this latissimus dorsi muscles around the heart to provide support. That is cardiomyoplasty. Special pacemaker is implanted to help the skeletal muscles to contract. So this latissimus dorsi is a skeletal muscles. They cannot contract. They are not having the property to contract. So we will also place some special pacemaker which will help the skeletal muscles to contract also. So ventricular assist device, this is also another method. Small mechanical pump implanted inside the chest or abdomen takes over the job of weak left ventricle. So in image, you can see there is a pump. A pump is placed inside the ventricle. Okay, so that what will be there? The left ventricle is so weak, it cannot pump the blood adequately. So that this machine, this ventricular assist device, this will be assisting the ventricle to adequately pump out the blood. So it will take over the job of the left weak ventricle. So from the left ventricle, this is the flowchart. The left ventricle, the inflow tube will be there. It will pump the blood out. The flow tube will be there to the aorta and other body. From the aorta, it will go to other body parts. Here you can see the left ventricle. From the left ventricle, you can see the inflow pump. So here it will pump, then the flow tube will be there. The flow tube will be going to the aorta, and from the aorta, it will be distributed to other body parts. Then if no other ways are there, the heart is totally damaged, destruction of the heart is happened. There is no other way. We tried so many surgical management and it is not working. Medical management also failed. Then we will go for heart transplantation. This is the last option. A heart transplantation or a cardiac transplant is a surgical treatment procedure performed on patients with end-stage heart failure or severe coronary artery disease when other medical or surgical treatments have failed. Okay, so that is heart transplantation. So these are the surgical management. Then we are moving on to our part, nursing management. Maintaining adequate cardiac output That is very important. Improving oxygenation of the patient. Restoring fluid volume. That means fluid volume will be excess in the body. So that should be resolved by giving Lasix and all. The fluid excretion will happen. Then improving activity tolerance. And we have to give health education. And health education, one of the main thing is dietary management also. Diet, what we have to do? Salt restricted diet. Sodium restriction, because the patient is already having sodium and fluid retention. So in diet, sodium restriction, we have to stress. Okay. So this is about the nursing management. So I'm going to ask some questions. I think you can answer this. We discussed all of these things in the class itself. Which of the following tests can be used for the diagnosis and assessment of the severity of heart failure? Severity of the heart failure, what we will assess? Option A, BNP. Option B, troponin. Option C, ANP. Or D, PSA. What is the answer? Can anyone say? Which of the following tests can be used for the diagnosis and assessment of the severity of heart failure? So the answer is BNP. And second question, visual disturbances in digoxin. We discussed these things in the class. And visual disturbances which we can expect in digoxin therapy. Option A, tunnel vision. B, blue vision. C, double vision or diplopia. D, yellow vision. What is the visual disturbance which we can observe in digoxin therapy? Answer is yellow vision or blurred vision. Yellow vision or blurred vision. So if anyone knows the answer, you can put it in the chat box. So this is the third question and the final question. In an adult patient, digoxin will be withheld if the pulse rate is below A, 40 beats per minute, B, 50 beats per minute, C, 60 beats per minute, D, 70 beats per minute. So in adults, you should note in adult patient, digoxin will be withheld if the pulse rate is below. Yeah, Gomati, your answer is B, Gomati, your answer is correct, 60 beats per minute. So this is about the heart failure. So in heart failure, we discussed also about core pulmonary and the types of cardiomyopathy, and we discussed in detail about the medical managements and surgical managements also, and digitalis therapy also we studied. So now these JIPMER exams are coming. So in JIPMER exams, you can expect theory questions, mostly deep from the theory they used to ask. So intensive study is very important. So the questions can come from any part. So study well out. Thank you.